All right, so let's talk about recurrent pregnancy loss. So first of all, what is recurrent pregnancy loss? Recurrent pregnancy loss is 2 or more losses, specifically clinical losses. So a clinical loss can either be defined as one in which there is ultrasound evidence of pregnancy or histopathologic confirmation of pregnancy in the uterus. This is a clinical loss is compared to what is also known as a chemical loss. So a chemical loss is like positive pregnancy test, a positive beta HCG that trends up, but you never get here. Okay, that's the difference between chemical and clinical. So the strict definition, the academic definition of recurrent pregnancy loss is 2 clinical losses. Now, that's not to minimize that someone who has multiple chemical losses is in some, less a state of distress, because it's still distressing whether it's a chemical or clinical. But when you do studies in recurrent pregnancy loss, the inclusion criteria usually is examining patients who have had greater than 2 or more clinical losses. So that's important because there's a higher prevalence of, finding something with more clinical losses than there is with chemical losses. Questions or comments about that distinction? Okay, so when it comes to recurrent pregnancy loss, it's really broken down into a couple things, and really it starts with genetics. So the most common reason people have a loss is because of embryo genetics, specifically aneuploidy. So the most common reason people have losses is because the embryo that implants is chromosomally abnormal and it just stops growing. So 60 to 80% of conceptuses will have a chromosome that end in miscarriage, have a chromosomal abnormality. A less common genetic problem is a genetic problem with the parent, specifically some sort of translocation. And this could be balanced, reciprocal, or something related. 4% roughly of parents who have recurrent pregnancy loss will have a translocation. And a translocation is, if you want to be kind of crude about it, if you have 2 chromosomes, let's say 18 and 21, a translocation, specifically a balanced translocation, is where part of one chromosome gets attached to another one. That makes the individual normal because the amount of DNA is balanced. But when that individual goes to make sperm or egg, the propensity of making a chromosomally abnormal gamete is much higher. So as a result, their likelihood of making chromosomal abnormal embryos is higher, and therefore their risk of miscarriage is higher. So if you want it, so this is why after 2 losses, if people miscarry, so that's translocation. As far as testing goes, let me back up. As far as testing goes, if patients have multiple losses with a subsequent loss, it makes sense to check a karyotype on the products of conception or do some genetic testing on doing some array testing. And then on the parents, it makes sense to check a karyotype if they've had 2 or more losses, both parents, that is. Okay. Questions or comments about genetics?
Does the Robertsonian translocation related to Down syndrome cause this at all?
It could, because one of the most common causes of miscarriage is trisomy 21, Turner's, and then T16. Okay, these are very common causes of aneuploidy and miscarriage. And the source of and it's important to know if someone has T21, what is the source of the trisomy? Is it truly just a new 21 or a duplicate 21, or is it a function of a translocation? All right, so the next thing is anatomy. So in patients who have recurrent pregnancy loss, you want to make sure the uterine anatomy is normal. So the uterine anatomy should look like this. But in patients with in patients with recurrent pregnancy loss, you want to make sure there's no polyp, there's no scar tissue, And then you also want to make sure there's no septum or that their uterine configuration is not abnormal. So some folks will have what's called a uterine septum, where their uterine cavity is divided by a kind of avascular space. And that can reduce the surface area from which the embryo can grow and receive supplementation from placenta and uterus. Okay. So you're looking for a uterine septum or other anomaly like scar or filling defect. Okay. Questions or comments about anatomy? The best way to evaluate anatomy is through a sonohyst, which is a special type of ultrasound in which you instill saline into the uterine cavity, and it gives you a nice view of the uterine configuration. So sonohyst is kind of the gold standard for evaluating the uterine cavity in someone with recurrent pregnancy loss. The next thing is hormones. So hormones, what you want to do is you want to make sure that the patient's TSH is normal. You want to make sure their prolactin is normal. And then I also like to check markers of ovarian reserve. So in patients with recurrent pregnancy loss, you want to make sure their body is not acting older than their age. It is not uncommon for patients with recurrent pregnancy loss to have some underlying infertility. So you want to also evaluate that, because those are two separate things. Infertility and recurrent pregnancy loss are two separate things. But sometimes patients with recurrent pregnancy loss will also have some underlying infertility. So it's important to ask patients, hey, you had 4 miscarriages. How long did it take you to conceive your pregnancies? Oh, it took me 2 years to conceive the first one, and then we had a miscarriage. It took me 6 months for the next one, and then it took 18 months for each of the next 2. That patient has infertility. So it's important to parse that out. Some things that other people talk about getting is thyroid peroxidase antibody. This is a little controversial, but a lot of people who do a workup for recurrent pregnancy loss will check this as well to see if they have any autoantibodies for thyroid disease. Questions or comments about hormones? Another thing you'll check is to make sure these people are not diabetic. So check a hemoglobin A1C. Moving on. The next thing is, so we talked genetics, hormones, anatomy. So the next thing is autoimmune disease. So autoimmune disease, specifically antiphospholipid antibody syndrome. In order to do this workup, usually you need to have 3 losses. And I don't think there really is a distinction in the diagnostic criteria for this workup, whether it's chemical or clinical. So usually after 3 losses, I do this workup, and you're checking beta-2 glycoprotein, antiphospholipid, anticardiolipin antibody, and you're looking for lupus anticoagulant. You know, people who are at risk for having APLS are the people who have losses that are like mid-trimester losses. They're folks who might have had a live birth that had severe preeclampsia or even HELP. Okay, those are patients who are at risk for APLS. So this is usually low yield, but it's part of the workup after 3 losses. Some people will still do the workup after 2 losses, but your likelihood of finding something is much lower. And these tests are expensive, so you want to make sure the patient has insurance coverage. So this is kind of where a lot of the standard workup starts and ends. And then we kind of go to more controversial, I wouldn't say controversial, is areas of study where there isn't a lot of great evidence. Infectious disease is probably kind of, might draw the line here. Infectious disease. So the infectious disease workup, you know, you're trying to see if there's any kind of plasma cells in the endometrium. Does this patient have chronic endometritis? So sometimes you'll biopsy these patients. Does an empiric course of antibiotics like doxycycline for 14 days warranted? The data to support this is okay at best. It's not great. So you'll see some inconsistencies among providers about whether they do this or not. Okay. The next thing is progesterone support. The data to support progesterone, empiric progesterone use is not great in patients with recurrent pregnancy loss. There's a meta-analysis that I cite that showed that there might be some benefit in those who have had 3 or more losses. There are some good papers from the Miscarriage Association in the UK looking at their populations, demonstrating some value in progesterone support. If you're gonna do it, you should do it vaginally, suppositories. Oral progesterone, probably not a good exercise. Another thing is, the natural killer cell testing. You'll hear people talk about natural killer cell testing. There's a lot of controversy about this. This is a fringe test and treatment strategy. Mainstream organizations do not believe there's enough evidence to support this. I personally, for transparency's sake, I don't find the evidence compelling to warrant this. We don't offer it. There are clinics that do, but I think it's important for patients and people to understand what this is and to read about it, specifically medical students, residents, and reproductive endocrinologists to review the literature on this. But basically, there's a to talk briefly about this, there is a certain level of inflammation that has to be present in the uterine cavity for implantation to occur. And if that level of inflammation, and I use the term inflammation not necessarily pejoratively, but in a benign way, if that level of inflammation is out of homeostasis, then you're probably not going to implant, goes the theory. So if you could measure inflammation in the uterine cavity and quantify whether it's high or too low, and maybe do something about it if it's too high or too low, then maybe you can improve implantation. So natural killer cell testing is one way of doing that. There are natural killer cells in the uterus. They are very different than natural killer cells elsewhere in the body. So current paradigms of natural killer cell testing rely on blood natural killer cell levels to approximate the natural killer cell population in the uterus, which has not been demonstrated to be accurate, at least consistently. So that's one problem I have. The next problem is if the natural killer, and that's actually kind of a big bugaboo. The next question is if the natural killer cell testing is positive, then what do you do about it? What interventions do you do? In the past, they gave IgG. They don't do that anymore because it's expensive. There's some variation in the batches. So what they do now is they give lipid infusions, which may reduce the natural killer cell population. So all of this is to say that the evidence is shaky to justify, first of all, we don't understand what the natural killer cell population in the uterus really does. Number two, we don't know, it does not appear that the natural killer cell population in the blood is a good approximation of the natural killer cell population in the uterus. So then number three, this lipid infusion that is purported to reduce the natural killer cell population in the blood, what is it doing to the natural killer cell population in the uterus? We don't really know accurately because one test is not a great marker for the uterine environment. So there are some challenges with this testing. Nonetheless, it still exists and patients pursue it and patients get pregnant after they do it. And is it the fact that they just got pregnant in another cycle, or is it a fact that they had this intervention? One will never know. But I do not offer this testing. And there are a lot of good papers that explain it and talk about it, and I encourage you to check it out. So that's recurrent pregnancy loss in a nutshell, the workup, the treatment. I think I'll just say a couple things, Sophie, about this. And one is 50 to 75% of the time, the workup for recurrent pregnancy loss is normal. You don't find anything. 40 to 55% of the time, the patient, if you did nothing, will take home a baby with their next pregnancy. Higher if they've had a prior live birth. Third thing is human reproduction is horribly inefficient. So miscarriage is not uncommon. So it's just important to point out, it's not uncommon, but it's very hard, and it's one of the most difficult things that we struggle with as human beings. So it's important to just be transparent and provide these patients with as much information and education as they can, so that they can make an informed decision about what makes sense moving forward. A lot of time the treatment is, we just leave kind of less is more. Sometimes I will treat these patients with empiric fertility treatments, like we'll start with Clomid, timed intercourse, try to get them to make more eggs in an effort to make more chromosomally normal embryos. Okay? Questions?
Yeah, that's pretty clear. Thank you.
No problem.